ADHD, substance abuse disorder, and she had a lot of medical comorbidities. She was one of my outpatients, and in working with her and kind of getting more of her history, she was given up for adoption at age 2, and then spent between ages 2 and 5 in multiple different foster homes, was removed always for her behavior, never because she was being abused and neglected in those homes. She eventually was adopted at age 5, and she had really good cohesion. She kind of meshed well with her adoptive family, but she had a lot of depression and anxiety and didn't do well in school. This kind of first led to me be wondering, where was this diagnosis for this woman at this point, kind of how much of her symptoms might be associated with something else rather than these other diagnoses she had. Next slide. So the second case was much more recently for me. I had a 12-year-old biracial female who I saw on the inpatient psych. She threw a heavy object, we never figured out exactly what it was, at her brother. She said that she did mean to harm him, so she was admitted to inpatient psychiatry. She was currently diagnosed with ADHD, ODD, and anxiety. When talking with her about kind of other history that she had in doing her intake, she was early in her life had witnessed her mom and father fight a lot verbally. Eventually they separated. There was a high emotionally expressive household. The mom then continued to have a series of really unstable relationships, and ultimately the child was just unable to engage in outpatient treatment, had a lot of behavioral problems at school, and kind of reported some non-specific PTSD symptoms. Definitely had nightmares, was clearly irritable, didn't like thinking about these stressors that had happened, but had never been diagnosed with PTSD. Next slide. So another question that I had, another case was a 16-year-old female in the outpatient clinic. I actually had several patients like this, presenting with depression with a previous suicide attempts and self-harm. They kind of report witnessing older siblings suffering with mental illness, although there was no threat to life. The older siblings never had suicidality, but there was a lot of conflict in the family, and ultimately the parents ended up separating. And all the parental attention, kind of as this kid was growing up, was towards their older sibling and their problems. Now I'm seeing this child, the older sibling's healthy, but this child still struggles with anxiety, a desire to be unobtrusive, and kind of constantly feeling like they're a burden to their parents, and reports a lot of emotional numbing. So I guess our first poll question, because we're doing those, is kind of, is this PTSD? So we're answering the first question. Or I guess we'll do all of them. So you have to answer all. Sam, can we get the results of the first poll with this, or do we need to wait till the end?
I think, let me see if everyone could, I'm getting some responses now. Do you want to give it a few minutes and maybe we could wait to the end, and I'll leave this poll open until.
Okay, that sounds great.
Okay,
so
sorry.
The first poll question, it's okay. We're trying something new. So our first poll question is just, is this PTSD for this case? We're also, so you've got two icons on this slide. The first is the poll, which means there'll be a poll question. The second is this clock with a question mark. That means we're doing a wait question. So I'm going to ask a question, and then I'm going to ask you all to put an answer in the chat box if you have access to it. And we'll wait a little bit for everyone to put in their responses. So the first wait question is kind of, what makes something trauma? Yes, so we're doing poll questions, which you should have seen a poll for. And then the second thing I'm doing is kind of a question for everyone. And if you could put an answer in the chat box, I'll type the questions as well as ask you. The first question is, what makes something trauma? So we'll wait a little bit and then I'll have you all send in your chats at the same time. If everyone has answers, because they're supposed to be quick, just send them in the chat and we can kind of see what people think makes something trauma. In the meantime, why don't we go to the next slide? Okay, so this is a really busy slide, and it kind of goes over Criterion A thank you, Thomas, for answering. It kind of goes over the current Criterion A and definitions of trauma. So the current definition is exposure to actual threatened death, serious injury, sexual violence in these ways. I think that we've kind of got a lot of ideas, kind of stress and helplessness, witnessing threat or real harm, just an event that's perceived as significantly dangerous, threat of physical harm, something that causes distress or impairs functioning. So we've kind of got a couple different definitions between this. It's an event that has to do with harm or something that impairs functioning. I would also add that right now for children under six and younger, it still has this exposure to actual or threatened death, but it also includes kind of impacting a caregiver, not just a person or others, but caregiver specific in Criterion A. So let's go to the next slide. So just a real quick to go over what today's plan is. So we're going to go over the history of trauma-related diagnoses. One of our objectives is to name a previous diagnosis of PTSD. Part of the idea is to understand how we got to this concept of a diagnosis, what's different about different exposures, what this looks like in kids, how we should assess for PTSD, reviewing PTSD in children, talking a little bit about ACEs and attachment disorders, risk factors for developing PTSD, and then I really want us to have a discussion. So the biggest purpose of this is for us to have a discussion about Criterion A and what makes something traumatic. So will be these weight questions, and we're going to try to do the polls. The poll will be open. We'll get an answer to all the questions at the end and kind of see where people are at. And I'm excited. So I hope you're all ready to participate. So far, I'm feeling pretty good and we're all warming up. Again, if I have connection issues, send me a chat and I'll adjust. Oh, right. So next slide. I have no disclosures because I'm an attorney. So going over our history, this piece I might go over kind of quickly. So before the DSM, the first known diagnosis that I could find in my research, the first known diagnosis I could find in my research was on disordered palpitation of the heart, which was diagnosed in Civil War Union soldiers in the 1860s. And it had this high suicidality, exhaustion. They drank a lot and they smoked a lot, and these were kind of things that let us know there might be something wrong. It was generally attributed to personal weakness, being stationed in an unnaturally hot and sunny climate, which at that time was just considered the whole southern United States, exertion during deployment, and they thought that maybe this had something to do with the weight distribution of in the soldiers' equipment, but they weren't really sure. Next slide. There was also a diagnosis called railway spine around the same time. So as railways were expanding, there were more and more accidents like the one seen here. Railway spine was characterized by physical paralysis, numbing, tingling, depression, memory loss, kind of all these other symptoms. And it was attributed not to personal weakness, but to a spinal concussion, and was generally treated with bed rest. And they did see that people did get better. Interestingly, along with railway spine, in Europe, there was kind of a similar diagnosis with carriage accidents. Generally speaking, horses and engines running around getting into accidents was causing people to have problems. Next slide. Then in the 1900s, we had war neurasthenia, which kind of came up with this medical diagnosis, generally a functional impairment of nerve and sense and motor, nerve sensing and motor power. There were some psychiatric symptoms that weren't really specified, but in general, the symptoms were pretty much the same as those described in railway spine. So there's starting to be a little bit of connection. Then the next one, next slide. We had World War I, and that's when we had this idea of shell shock. So as we know, shell shock was attributed to the compression and decompression of the brain, being too close to explosions. It was also called combat exhaustion or battle fatigue. There's a quote that they use for diagnosing shell shock in the medical school in London. The exciting cause is some special psychic shock. Horrible sights are the most frequent and potent factor in the production of this disease. Losses and the fright of being buried are also important. So that was kind of this diagnosis, but it led to the pension problem. So in World War I, British soldiers all had pensions for their service. And after World War I, 65,000 of soldiers were diagnosed with shell shock and received pensions for this. By the time World War II came around, there were 450,000 soldiers that had shell shock listed as a reason why they were receiving pensions and unable to be employed, which is almost 7 times the number of soldiers. At that time, after World War II, they started to think this is less about a personal weakness and became more generalized, not necessarily related to an explosion, but definitely related to stress received in combat. Next slide. So this is a picture actually of the World War II Memorial here in San Francisco. It's very beautiful there and it's near the ocean. So by the 1952, the DSM-1 came out and they had this diagnosis of gross stress reaction, which was a situational personality disorder. Their quote there was, under conditions of great or unusual stress, the diagnosis is justified in situations where the individual has been exposed to severe physical demands or extreme emotional stress, such as combat or a civilian catastrophe. By civilian catastrophe, they reference fires, earthquakes, explosions, railway accidents, but kind of this idea that it's something that is great and unusual stress. By the time DSM-2 came around, we have transient situational disturbances, which was a different diagnosis. Was considered this acute reaction. This was still transient, but it did encompass other ranges of stressors, not just extremely intolerable or unusable stressors. There were pervasive, if a patient had pervasive or long-term symptoms, then it was considered that that was a personality disorder. So there should be an acute reaction to stress that's understandable, but if it lasts for too long, then it was attributed to personal weakness and a personality disorder. This would be our second poll question, which you guys have. If you know the next event that led to PTSD as a formal diagnosis? The options are the Vietnam War, the Korean War, the feminist movement, civil rights movement, or just the Beatles. They were very destructive.
The Vietnam War.
That's correct. Next slide. Sam? Oh, I froze.
Can you see the next slide?
I cannot. There it is. Okay. I think I had some internet issues there. Okay, so yes, it was the Vietnam War that led to this development of the official PTSD diagnosis. And in the 1970s, there was this post-Vietnam syndrome, and that was not an official diagnosis in the DSM, but was being treated. Um, and then in the DSM-3 in 1980, there was this official diagnosis. Actually, to make this happen, a lot of the veterans from Vietnam did have to kind of protest and fight and rally and advocate for themselves for this to be an official diagnosis. The event outside the range of usual human experiences that's markedly distressing to almost anyone. This allowed for PTSD in non-combatants, so not just the soldiers, but also their medical officers. And it was specific for longer-term reactions, anything lasting longer than a month. That was really important because we know that PTSD, especially in our veterans, we have Vietnam veterans now who many, many decades later are still suffering with symptoms of PTSD. Next slide. Fantastic. I'm sorry, I think I'm having a little bit of delay on my end, so I'll try to make this keep on going. So now in DSM-4, or most recently DSM-4, we have another definition of trauma. This included specifically exposed traumatic event in which there was real or threatened death, injury, or threat to physical integrity. So they added the physical integrity to account for sexual assault survivors. Before that, they weren't necessarily given a diagnosis of PTSD. So there was a lot of research and a very big push towards including sexual assault survivors. They also had this piece, which isn't in Criterion A, but I think often gets cited as a change between DSM-4 and DSM-5, of this response involving fear and hopelessness and horror. Next slide. So now we have DSM-5, exposure to actual or threatened death, serious injury, or sexual violence explicitly. That this is a definition of trauma. In children specifically, this exposure has to do with witnessing the events, experiencing them, or learning about it as it occurred to a parent or caregiver, which doesn't necessarily include learning about this happening to someone in general, specifically their parents or caregiver being threatened. Next slide. So this does include other exposures for adults. And for adults, they're usually talking about first responders, medical professionals, other people who care for those exposed. But there are other ideas about exposure, something like continuous trauma, which might be something kind of like this idea of minority stress or a post-traumatic slave syndrome or homelessness, overcrowding. There's a lot of different examples of kind of continuous trauma, things that people are going through that are still extraordinarily stressful. In these, people can develop these internalizing and externalizing symptoms. A lot of times these stressors and this trauma isn't necessarily considered pathologic, but it still has really negative impacts. One big thing that's kind of really common with this idea of continuous trauma is these are stressors that are common and not normal. One of our next weight questions, so yay participation. What are some other things that are common but not normal in terms of stressors or traumas? So type that in and hold on to press send, and we'll press send in just a little bit. All right, go ahead and press send. isolation, fear, racism and poverty. Yeah, I think that there's a lot of these. I think homelessness, hunger is another experience I think is very common, unfortunately, in our country, isn't normal and can cause kind of long-term perceptions to be different. Immigration, that's a really good example. Next slide. So there's this other and ongoing research about other exposures, considering vicarious exposures to youth from at-risk communities. So this was a study that was looking at online exposure of racially salient trauma. So looking at videos of immigration raids or police violence against African-American people, which we know is very, very prevalent right now. And in this study, they were able to correlate the hours of online exposure and with increased exposure, there was increased symptoms, PTSD, depression symptoms. Of note, they only screened for symptoms, and this wasn't necessarily diagnostic in any way, but there was these increased symptoms, and females reported increased symptoms with decreased exposures. So another weight question for us, what are specific symptoms that we might need to look at in a pediatric population? So hold on to that. And go ahead and press send. Yeah, so the symptoms, school avoidance, nightmares, avoidance, distractibility, bullying and social media are definitely experiences that that children are more likely to receive, but in terms of the symptoms, withdrawal, I think, is one that we see a lot in kids, regression in behaviors, this decrease of interest. And these are all things we see particularly in kids. We'll talk more about that in just a little bit. Next slide, please. So when we think about presentations of PTSD or kind of these trauma reactions in children and adolescents, one study that was looking at prevalence of this on inpatient units, 90% of the patients reported exposure to trauma, but only 25% met criteria using their screening tool. Many of them are diagnosed with bipolar or an antipsychotic medication, but hadn't actually been assessed for trauma. So we're seeing things, but not necessarily catching it. The poll question here is, do you always or do you regularly ask about trauma exposure in your patients? Next slide. So in children 6 and younger, which is a new category that's kind of specifically talked about in the DSM, there is this challenge to find a balance between what is a traumatic experience and what is a non-traumatic experience. I recently had an example where I was told about a patient who had witnessed their grandmother die. They found her body, and someone was saying, oh my goodness, this is so traumatic. But there's also, we're humans and people have been unfortunately dying since as long as we've been humans. So many people have found dead relatives and not necessarily been diagnosed with PTSD. I think there's this question of, is this experience clearly traumatic? Criterion A requires an ability to do a threat appraisal, but we do know that children under 6 can't appraise threat for themselves. The severity of an injury or severity of the event is not a good predictor for developing PTSD. Parental reaction, children refer to their parents for the actual threat appraisal, so that can help, but it's still not necessarily a clear diagnosis, a clear way to say if someone has been exposed to a trauma. The symptoms in children, so children younger than 3 can't talk, and parents often don't see the internalizing symptoms, things like withdrawal, restricted interests, the nightmares, just kind of feeling sad all the time they may not know. The re-experiencing symptoms, so we see children re-experience symptoms, not only do they have these intrusive memories, but we see it in their play that they may act out the trauma. That tends to peak at age 4, and then they don't necessarily have as much re-experiencing. The avoidance of these things, avoidance of triggers, not talking about it, the avoidance increases until age 3, and we kind of continue to see that. We also see for children a lot of externalizing symptoms. That's a lot of irritability, acting out. That can also be seen as a part of avoidance. The functional impairment piece, I think, is also really relevant for children. So children at different ages have different developmental demands, and by functional impairment, we really mean not successfully completing those developmental demands. So those are different at different ages. We do see a lot of misattribution. A lot of kids get diagnosed with separation anxiety, ODD, ADHD, for children that are younger than 6. So this is clearly a place where we're seeing, we definitely seeing these symptoms, but what we're calling it can be different. Next slide. So a quick kind of detour for neurologic development for our kind of medical side. So we do know in adults there are impaired connections between the emotion regulation in response to negative stimuli. So there's decreased frontal lobe action that's able to kind of tolerate and kind of adjust for this emotional stimuli, and there's increased limbic action. More or less for children, multiple areas are affected. Specifically, the hippocampus tends to be smaller in volume. The amygdala is generally just not average in volume. Sometimes it's larger, sometimes it's smaller. And the prefrontal lobe has poor coupling, so it tends to not be as strong, and the volume can be a little bit smaller. And these timelines, usually we see these effects around these ages. So the hippocampus is usually affected before age 14, the amygdala around age 10 to 11, and the prefrontal volume and those connections are usually affected before age 16. Young children can develop this frontal limbic coupling to compensate, in which case we may see less re-experiencing. They may not play or kind of show these re-experiencing symptoms, but they will have dissociations more so. In fact, that dissociation it starts as protective, but by the time they're adults, it starts to be pathologic. Next slide. So in older children, this was a very interesting study I found. So there's low rates of diagnosis. There's this whole gap for children that are 7 to 18. We do have specific criteria for kids that are 6 and under, but this whole huge range of kids. We see a high rate of symptoms, but they're not necessarily getting diagnosed. This study used the criteria for children that were younger than 6 for all children, and they did find increased diagnosis for kids that were up to 12 years old, but not 13 and older. You can see in this figure by the other children, younger children, using this diagnosis, using the criteria for very young children, they get this whole circle, and if you kind of go smaller and smaller, you get fewer children. But for adolescents, it doesn't really seem to be a difference. The avoidance and negative cognitions can be useful more in adolescents, less in late in age children. The avoidance symptoms can kind of are present until age 3, and then they tend to go away, and we see other types of symptoms. The weight question here is kind of how do you screen for PTSD? Do you have a tool you use or a specific question you ask? So type that in our chat box. Go ahead and press send, and we'll go to the next slide. So this is a table of some of the screeners. There are a lot of different screeners for PTSD in children. The UCLA reaction index is very well studied and kind of it costs a little bit of money to start, but it has a lot of data to back it up. These are all just self-filled screeners. I figured that it'd be easier than also including the ones that are clinician performed. But the National Child Traumatic Stress Network does have a number of different screeners, pros and cons, kind of a deep dive into a lot of them. One other one I wanted to highlight that I didn't put on the table was the PTSD in preschool age children, the PTSD PAC. Specifically for ages 3 to 5, it's parents parents fill it out. There's no child component there, but I think that's also important for these very young children screeners. If anyone wants to take a screenshot of this to kind of think about what they might want to use and which one might be appropriate, you're more than welcome to. And next slide. So another definition is kind of what the SAMHSA definition of, which is pretty much, I like to think of as the government definition of trauma, an event or a series of events or circumstances that's experienced as physically or emotionally harmful or life-threatening and has lasting adverse effects on individuals' function, well-being. I think if you scroll up in our chat box into our first question of what is trauma, it's more in line with this definition of kind of something that causes harm. Not necessarily, sometimes it has to be life-threatening, but it's a question of does it have to be? And also that this causes long-lasting effects. I think that's an important thing that we're catching in this definition that we don't really see in Criterion A and in our definition of something that is a trauma. Next slide. I wanted to take a moment just to talk about the ACEs and the PEARLs. In the past, when I've asked other coworkers and different providers about what they use, some people have told me that they use the ACEs, but the ACEs doesn't really screen for trauma. The original study is just looking at child abuse and household dysfunction. So they had 3 questions about child abuse. Unfortunately and interestingly, it's much more common than we'd like it to be. But then the 4 questions about household dysfunction. So that was things such as substance use, violence in the house, exposure to mental illness, exposure to criminal behavior. And these other questions were about childhood or household dysfunction, not necessarily trauma. And they basically just used this to correlate with health risk factors, finding that as people had 4 or more ACEs, only 14% had 0 of these risk factors or kind of health risk factors: obesity, smoking, substance use, things like that. So we're seeing a correlation between household dysfunction and abuse and then later health effects, but not necessarily trauma. Interestingly, the PEARLs, the pediatric ACEs and related life event screener, is ongoing. It's an interesting study. It uses the ACEs and then also kind of has other measures for toxic stress. It has a parent report for all children and then self-report for children that are older than 12. It's available free online, so that's another kind of resource, and if you're interested in using it to kind of screen for this toxic stress. Next slide. So kind of rounding out kind of this view of other stressors, so attachment disorders and PTSD. This is a picture of Korean orphans. But if we look at the diagnostic criteria for attachment disorder, we kind of see this pathological primary care. That's in Criterion C. But there's a kind of dilemma here. If a child has lost their primary caregiver due to a terrible accident versus natural causes, they may be diagnosed with PTSD versus an attachment disorder. There's a really big difference there. And depending on what they're diagnosed with, they may or may not get different types of treatment. We have a lot of evidence-based treatment for PTSD, less so for attachment disorder. So there's a big question there. And in children who are older than 5 years old, who lose their primary caregiver or have this Criterion C, there's really no diagnosis. So there's a proposal for developmental trauma disorder, which includes interpersonal trauma, that might be worth thinking about. Next slide. So I'd like to introduce one of my 2 discussants. Lydia Santiago is a PhD. She's a licensed child psychologist who is the UCSF Department of Psychiatry clinical professor, and she's the clinical coordinator of the Child and Adolescent Support, Advocacy, and Resource Center, which is a child advocacy center for San Francisco County where children with abuse histories are provided with forensic screening, forensic evaluations, and mental health services. Dr. Santiago, take it away.
Thank you, Dr. Urban. So I'm going to just briefly give an overview of risk and protective factors for children. So I know she wants to get on to the discussion part, and I know I'm checking the clock where time is short. But I think in the field we're looking at protective and risk factors. At least most people are looking at it from a systemic kind of way, in that there tends to be cascading risk and cascading protective factors at different levels. And you can look at the individual, the child level, the family level, the school level, and the community level. And there's usually interlocking or cascading domino effects usually in each of these levels. And so we know that for developing PTSD, one of the most protective factors is the caregiver relationship. That's actually the factor that predicts the child's ability to improve or get better from PTSD, or even not develop PTSD symptoms. Is the caregiver attachment relationship. As we know, children don't don't come with coping mechanisms. The parent or the caregiver is the one that helps the child understand, make sense of the world. And so it's really important for that caregiver to provide safety for the child. And if the parent themselves is impacted and is not able to do that, then you're providing sort of the network and the foundation for the child in the future. And so that is a strong risk factor or protective factor, depending on the parent. If the parent has good healthy coping mechanisms, are able to self-regulate themselves, then they're going to be able to model for the child appropriate self-regulation techniques and coping skills. What the other factor is the parental management systems, what we call parental management systems. So this is his ability for the parent to develop routines, rituals, predictability for the child, because this provides safety for the child. Being able to have a predictable environment provides safety for the child and comfort, and also helps the child develop a sense of control, and that they have some impact on the world. The other factors are, in terms of the individual, is if the child has prior emotional or behavioral, developmental, medical issues. That can also, those are individual factors on the child that determine their ability to be able to respond or cope with any traumatic event that happens to them later in their life. So a sense of the relationship is the most critical piece. Like I said, the caregiver relationship is the most critical piece for the child. And sense of belonging in the cohesion, family cohesion and belonging, which again, that's part of the parental management system. Having at the other levels is school. If it's a child is doing well at school, is academically performing at grade level, doing well, has cognitive, has developed appropriate cognitive skills and is able to do well at school academically, that's usually a good predictor. And in terms of the community, as we know, living in a community that is safe, that there is social connection, that there's ability to trust and feel involved and feel like you're a valuable member of the community. Those are all kind of protective factors that impact on the child. And as we know, trauma will impact differently developmentally, not only on the developmental cycle of the individual child, but the developmental cycle of the family, because then you have families at different developmental cycle of their process. So usually those are the most important factors in terms of thinking about protective factors for children and families.
Thank you so much.
Okay.
I just really want to stick to our discussion. So next slide. So we're going to try to use breakout rooms. We're going to see how it goes. So we'll set you all into kind of different breakout rooms. They're all going to be randomly assigned. So we'll see what happens. And we're going to kind of try to reenact a conversation that happened at the last DSM meeting. So talking about criterion A, what is trauma, how we define it. We'll try to send questions to you guys in the breakout rooms, but these are basically what we want you guys to talk about. Try to define trauma. What's a big T trauma? So what's something that's kind of everyone can say is trauma? What's a little T trauma? These are other traumas that I think colloquially things that are kind of common but not abnormal, or kind of things that are also stressors. Is there a difference, or does that difference matter? Trying to define something that's complex trauma, talking about developmental, try to define minority stress and defining developmental attachment trauma. And are these big T's or little T's? So I'm gonna put these in the chat box real quick. And Sam is gonna get the breakout rooms ready. And we'll try to see how this goes. We'll do breakout rooms for about maybe 10, 12 minutes, and hopefully give my second discussant, Dr. Graham, some time at the end. All right. Sam, why don't we send us to the break rooms? Okay, so I think that we almost all be back. Thank you guys so much. I hope that your discussions were as useful as mine, and kind of the goal is not necessarily to come, there's no right answers, just having an ongoing conversation. So we have our poll kind of at the end there. And Sam, move to the next slide, and I'll introduce Dr. Graham as we kind of round out. So Dr. Regina Graham is the Medical Director of Psychiatry and Mental Health and Child Development, as well as and the Medical Director of the Psychiatry Consult Liaison Service at UCSF Benioff Hospital in Oakland. She's an Associate Clinical Professor at UCSF in the Department of Psychiatry and Behavioral Sciences. Thank you so much, Dr. Graham.
Thank you. So definitely, I had a great setup from Dr. Santiago from what I'm talking about. What I have to talk about is going to go pretty quickly. So just thinking about trauma, and that we're all living through a trauma right now of COVID-19 pandemic. And even though we're all affected differently based on our various risk and protective factors we're bringing to the pandemic, and relating it to the families that we work with, that thinking about resiliency and how can what kind of things are going to predict someone's ability to adapt positively to this adversity that we're facing. So thinking about protective factors for trying to buffer this adversity during COVID-19 pandemic. As Dr. Santiago pointed out, the most important one is presence of a sensitive and caring adult, which ideally will be a caregiver, but it could be other adults in the child's life. And ideally, if this connection could be face-to-face. However, even virtual supports help, and that includes us as clinicians. The other protective factor would be meeting basic needs. So food, shelter, clothing, healthcare, mental and physical health. And so as much as we can encourage families that we're working with that it's okay to ask for help if they do need it right now, for food banks, trying to get shelter, etc., that there's no shame in needing extra help right now if it's something that's a totally new scenario for you being in that position. The third protective factor would be caregivers giving children emotional support. And we could think about the 3 R's, reassurance, routines, and then helping with affect regulation, Dr. Santiago talked about. The fourth protective factor would be encouraging caregivers to get their own supports. So finding moments in the day to do their own self-care, even if it's 5 minutes, 10 minutes, that they have to reminding them to put the oxygen mask on first before trying to help others. And then the last protective factor would be social connectedness to family, extended family, immediate family, friends, and community. And again, face-to-face would be ideal, but in these times that may have to be virtual social connection. And all of these protective factors, we can try to encourage our families to engage in to get through the pandemic. Thank you.
Thank you very much, Dr. Graham. So I know that we're at time, basically. So if anyone needs to leave, thank you so much for being here. We'll go next slide. I'm going to be, as part of my scholarly work for my training, I kind of next steps from this I really got stuck with this question of kind of if we need to define trauma, then what is trauma-informed care? What does it look like? What does it mean in different fields of medicine? And so these are questions that I kind of still had. Next slide. So I'll be doing a kind of project to survey different common definitions of trauma in different fields of medicine and wondering and kind of looking at what is trauma-informed care. SAMHSA has some definitions. If you Google trauma-informed care in SAMHSA, they have a pretty extensive workbook about what that can look like. But I thought that I still had some questions about how does the medical context look at this? So next slide has my references. And thank you. Feel free to reach out with questions. I'm going to stay on for 5-10 minutes if there are more questions. So feel free to ask. And otherwise, thank you so much. The slides, can they be emailed? I'm happy to email you my slides if you send me your email.
Thank you so much, Dr. Urban, Dr. Graham, and Dr. Santiago. What a great talk. I love this format of polls and breakout groups. Thank you for being a trailblazer to that extent, and for all your amazing work, Dr. Urban. Thank you so much. So I will actually have to leave, so I have to run a class now. But Sam will stay on to help run Q&A for a little bit. Thank you very much.